Hello, my name is Danny Issa. I'm an interventional endoscopist at the University of California in Los Angeles. And today, on behalf of my co-authors, I'm excited to share with you the key findings of our study entitled Clinical Outcomes and Learning Curve of Endoscopic Retrograde Cholangiopancreatography during Advanced Endoscopy Training, a comparison of supine versus prone positioning, which will be published in the forthcoming issue of Gastrointestinal Endoscopy. Just a little bit of a background. ERCP can be performed with the patient in supine or prone position. In the United States, the majority of ERCPs are performed with the patient in the prone position. Each one of those two positions has its advantage and disadvantage. The prone position, for example, is considered optimal for biliary cannulation, and it aligns ergonomically very well with the endoscopist. Supine position, on the other hand, offers ease in transferring the patient to and from the fluoroscopy table and allows for better control of the airways and quicker resuscitation maneuvers. ERCP is necessary in certain conditions, for example, morbidly obese patients, patients on the ventilator, patients with recent abdominal surgery, ascites, as well as pregnant patients. The available studies comparing supine versus prone positions are limited by two main factors. Number one, the operator's prior experience and comfort level with one more than the other position of the patient. And number two, the heterogeneity of primary endpoints when it comes to the procedure outcomes. From a learning perspective, ERCP is one of the most technically demanding procedures, and it requires specific skills to perform the procedure independently at a high level while maximizing success rate and minimizing the rate of adverse events and the risk of procedure failure. Cannulation of the native papilla is widely considered the benchmark of successful ERCP. We prospectively evaluated all patients undergoing ERCP by a supervised advanced endoscopy trainee at the tertiary care referral center. The trainee was given universally 5 attempts for each biliary cannulation. To be included, the patients had to meet all of the following criteria: adult patients, native papilla, and cannulation performed by the trainee until at least 5 cannulation attempts were made. Exclusion criteria included prior biliary or pancreatic interventions, altered anatomy, as well as insufficient documentation regards the procedure's outcomes. 89 out of 584 ERCPs met the inclusion criteria and were included in this study. Among those, 64 patients underwent ERCP by the advanced endoscopy trainee in the supine position, and 25 patients underwent ERCP in the prone positions. The primary outcome of successful biliary cannulation by a trainee was comparable between the two groups, and it was 69% for supine ERCP versus 68% for the prone ERCP. We then excluded patients who had or deemed to have difficult biliary cannulation per standard definition, and the rate of biliary cannulation remained comparable between the two groups, and it was 84% for supine versus 80% for prone. In terms of secondary outcomes, patients in the supine position had a shorter time to position duration, which meant that achieving a good papillary visualization was faster in patients undergoing supine ERCP compared to prone ERCP. The procedure duration was also shorter in supine position at 32 minutes in average compared to the prone position at 42 minutes in average. Similarly, the total procedure duration was significantly shorter in the supine position compared to prone position. In fact, patients in the supine group saved an average of 38 minutes in the total room turnover time compared to patients in the prone position. We then assessed the learning curve by measuring the outcomes quarterly throughout the academic year. A stepwise increase in the rate of successful biliary cannulation was seen in both positions. For example, in the supine position, the rate improved from 54% to 90%. In the prone position, it improved from 56% to 83%. When divided by quarterly time marks, cannulation rate increased more in the supine position compared to the prone position, which may suggest a steeper learning curve to achieve competency as the trainee gets adjusted to the specifics of the supine ERCP position compared to the prone position. One area that was not discussed at length in the manuscript is the importance of the ergonomics of the room during ERCP in each of those two positions. As this illustration depicts, in the prone position, the endoscopist is standing very close to the fluoroscopy table, and both the endoscopic and the fluoroscopic monitors are positioned across the table from the endoscopist. On the other hand, in the supine position, the endoscopist actually takes a step away from the fluoroscopy bed and stretches the shaft of the scope a little bit. Ideally, the monitors should be positioned behind the head of the table at about 11 o'clock orientation, as shown in this picture. In conclusion, this study showed no difference in biliary cannulation rate or adverse events between supine and prone ERCP when performed by advanced endoscopy trainee. Supine position saved on total procedure time as well as room turnover time, which may increase endoscopy unit efficiency and productivity. Learning curves towards competence seem to be steeper in supine position. While endoscopists need to have knowledge and comfort in both ERCP positions, this study suggests early training in supine and prone positions simultaneously for advanced endoscopy trainees. I would like to thank the editors of GIE and the ASGE for the opportunity and the platform to share our study's findings, and the viewers who tuned into this author's interview. And sure, you can access the full article at GIE.